Good morning, everyone, and welcome from ACC 26 here in New Orleans. I'm Andrea Villatore from San Raffaele Hospital in Milan, Italy, and I'm pleased to be joined here today by Dr. Victoria Parikh, Associate Professor at Stanford University. So,
Thanks
hi,
so much for
Victoria.
having me, Andrea, and to the FIT program for putting this together.
Thank you. Thank you for being here. So today we'll be discussing about the preliminary data from phase 1/2 trial Heroic PKP2 by Lexeo Therapeutics evaluating gene therapy for the treatment of PKP2 related arrhythmogenic cardiomyopathy. So Dr. Parikh, to begin, could you provide us a general overview of the study design, in particular the patient population enrolled and also the specific drug being investigated?
Absolutely, Andrea. Thank you for asking. So, as you know, arrhythmogenic cardiomyopathy is a rare disease, but it's a really devastating disease, right? So, up to 23% of these folks are thought to present with sudden cardiac arrest. And then, even those that don't end up with a long history of multiple VTs, sustained VT ablation, lots of antiarrhythmics, and then eventually heart failure, right sided heart failure, often that we don't have a therapy for. So, the goal of this trial was to use a precision therapy where we can make a genetic diagnosis in these patients. The majority of genetic diagnoses in arrhythmogenic cardiomyopathy are, in fact, a loss of function variant or mutation in plakophilin 2. And to be able to replace that gene, right? Give a good copy of that gene back to the heart. So the way that this drug, which is called LX2020, does that is it uses an AAV, which is an adeno-associated virus capsid. Now, AAVs don't replicate, which is good news, but they can actually be used as a delivery mechanism to put a new copy of plakophilin 2 into the heart so that the heart can then do what it's supposed to do. What it's supposed to do is go to the desmosome, which of course causes connections between cardiomyocytes, and restore both the electrical function of the heart as well as its contractility. So the idea here is that you can dose a patient with this AAV containing this new copy of PKP2, and that should go to their heart and help to repair the damage that's been done by not having that copy for so long.
Okay, thank you. This is really interesting. So now turning to the safety profile, how well was LX2020 tolerated by the patients? And can you also comment the key challenges in gene therapy for cardiovascular diseases, such as the cardiac targeted delivery of the drug and also the immune-related adverse events such as myocarditis?
Yeah, critical questions, Andrea. So, gene therapy at large, not just cardiac gene therapy, of course, has a storied history that started back in the early 2000s. And one of the major things that we need to be cognitive of as clinicians with any therapy is that we're not causing more harm than good, right? So at this juncture, we're finally at a point where we think we can safely give gene therapy using these AAV capsids. And the way that we do that is to immunosuppress the participant or the future patient by giving them prednisone and sirolimus in this trial. Other trials add rituximab in order to suppress that inflammatory response, allow the AAV to do its job, and then release that slowly in a very controlled manner to ensure that we don't see, for example, prolonged liver damage, etc. Now, LX2020 was very well tolerated, certainly in the high dose cohort. So as you mentioned, this is a dose escalation trial. In the high dose cohort, as we withdrew prednisone and sirolimus, we started to see AST and ALT climb. So we went back with more prednisone and sirolimus and then retried the taper. And in all patients in which we saw the transaminitis, when we did that, we saw resolution of that liver response. And really critically, we didn't see any issue with the synthetic function of the liver, right? So this is truly a transaminitis that we are treating successfully and is resolving. The other thing that comes up when we think about AAV delivery to the heart specifically, right? I mean, we know that these many of these gene therapies go to the liver quite easily, right? We know the liver is the organ of the body that takes in everything you put in the blood and sort of deals with it. That also means that often it's hard for those things to get to the heart. So AAVs, some of them, these serotypes, right? This is, in this case, RH10, will go to the heart with tissue specificity and deliver that piece of DNA. So here, AAV RH10 in preclinical studies did show 1.5 to 2x efficacy of delivery to the heart as compared to other AAV serotypes. So I think the combination of a really thoughtful immunotherapy or immune suppression regimen, along with the lowest dose possible that you think is going to create an effect, meaning going to positively influence the patient's heart, is the key here. And with LX 2020, we've seen that we've been able to do this safely. I should also mention that we did not see any clinically significant complement activation, no TMA, as has been reported in earlier trials in the neurologic space. We do also think about whether or not we're going to cause arrhythmias, right, when we deliver to the heart. And I think, you'll probably get to this, but there was one serious adverse event in this trial of a sustained VT event. But what's also important to remember is that these patients, we don't have a control group here, right? We have an open label dose escalation study. So what we're looking at is a population of patients who at baseline are at risk of having, right, prolonged or sustained VT. You can actually calculate that because we have great long-term follow-up studies of these patients, thanks to great work done at Hopkins and in Europe and many other places. So you can look at a baseline patient and you can say, what is their risk in the next year of having, right, sustained VT? And it turns out that the average risk in the population that of participants in this trial was about 16% in 1 year, right? So 1 out of 10 of them had a sustained VT episode. And in fact, that particular individual had VT before, right? And so this means that that we are dealing with a high risk population here. And so as we continue to follow up with these patients, we hope that we will continue to see more clinical signal of efficacy and improvement.
Perfect. So I think this is overall really reassuring for our patients. So now coming to the hot part of the results, so the efficacy. So what clinical benefits have been observed so far in this phase 1/2 trial? And also, can you comment about the arrhythmic burden reduction?
Yeah, thank you. Great question. So again, we're talking about an arrhythmogenic cardiomyopathy here. So the things that we expect to see earliest are going to be a reduction in that arrhythmic burden. But with this type of therapy, the first question you want to ask is, do we expect it to work? Because did it actually even deliver that new copy of the gene, right? So we have data to suggest that on average, the protein expression of PKP2 went up in the population as compared to prior. We have a biopsy before treatment, and then we have one 3 months after treatment. And so on average, we see an increase in PKP2 expression at the protein level, which is very reassuring. And then the question of follow-up is really going to be an important one, right? So at the lower dose, we did not see a big improvement in PVCs or NSVT at 12 months. But this is, again, a dose escalation trial, right? So in this now we know safe higher dose, we have measured PVC burden, change in PVC burden over time, change in NSVT burden over time. And then, of course, we're measuring cardiac structure and patient symptoms. We do see that in 3 out of the 5 patients in whom we have 6 or 9-month follow-up for the high dose cohort, there is an improvement in NSVT burden. We see that there was one patient in that cohort that had only 2 episodes of NSVT in 7 days to start, and they went to 4, right? So not clear that that's clinically significant, certainly not an improvement. And then there was another patient that had an increase in their NSVT. So this is early days. We are still collecting data on this cohort. With a genetic disease that you've lived with your whole life, we don't know how long it's going to take to see improvements, but I think that we have an early encouraging signal, and that goes along with actually improved patient symptoms in an open label trial. So we're looking forward to the 12 months results.
Great, thank you. So finally, looking ahead, in your opinion, what future perspectives do you see for extending gene therapy also to other forms of ACM, so DSP-related ACM or also gene-negative ACM?
Mm-hmm. I think that we want to use tools that are the lowest possible risk for the population that we're treating. The population that we're talking about here with ACM, we have no therapy for, right? So we want to start with folks in whom we know that the mechanism of disease is tied to the therapy. So for example, you mentioned DSP is another gene where you have a loss of function, and that leads to ACM, similar mechanism at the desmosome, right? So yes, if we can replace DSP, that will be great. DSP is very big. And it turns out that AAVs only have a certain capacity for delivery. So I think that what we need to work on is understanding what common mechanisms exist in these ACM diseases, and then try to identify for those who don't have a genetic diagnosis or have a genetic diagnosis but in a gene we can't replace very easily, what are the common factors that we can think about manipulating either with an AAV therapy or with another type of therapy in order to help these patients.
Perfect. Thank you very much. So,
Thank you.
thank you. So,
Great.
enjoy ACC.
Will do. Thank you.
Thank you. Okay. So, good morning, everyone, and welcome to ACC 26 here in New Orleans. I am Andrea Villatore from San Raffaele Hospital in Milan, Italy, and I'm pleased to be joined here today by Dr. Victoria Parikh, Associate Professor of Medicine at Stanford University. So, Dr. Parikh, could you summarize the results of the preliminary data from phase 1/2 Heroic PKP2 trial by Lexeo Therapeutics?
Thank you so much, Andrea, and thank you for the invitation from Fits on the Go. I'm very excited to be here today representing the heroic PKP2 investigators. So this was a dose escalation phase 1/2 trial of LX 2020, which is an AAV-based gene replacement therapy for plakophilin 2 or PKP2 ACM. So what that means is that plakophilin 2 in these patients is broken, and we need to give them a working copy, and we do that via delivery using an AAV. The major, things that we wanted to assess in this trial, of course, were the safety of the drug, and that's in particular important given that we're studying gene therapy here. And then, of course, looking for early signs of efficacy. So in terms of the safety, the drug was really well tolerated. There was no clinically significant complement activation. There were certainly no episodes of TMA as have been reported in earlier gene therapy trials, for example, in the neurologic space. We did see in the high dose cohort that there were elevations in transaminases in AST and ALT. Those occurred at the time of withdrawal of immune suppression, so prednisone and sirolimus in this trial. And with reinstitution of that immune suppression and slower tapering, those transaminitis events resolved. So I think overall, really an encouraging safety profile for this therapy. There was one serious adverse event which has been previously disclosed, and that was a patient who experienced sustained VT after dosing. This is, of course, a disease in which sustained VT is very common, and we think that continued monitoring going forward will be important to inform our understanding of long-term safety. But I don't think that we expect that a single sustained VT episode among 10 patients with, right-sided ACM is necessarily indicative of a toxicity. And then in terms of early efficacy data, we know now from this trial and from, post-treatment biopsies of the heart that these patients are getting the gene therapy to their heart, that it's turning into protein, which is what we want it to do. And we're continuing to follow them. It's early days, 6 and 9 month follow-up for the high dose cohort in terms of their improvement of PVCs and NSVT. So looking forward to longer term data for these patients and for everyone who's affected by ACM.
Thank you.
Thank you.